based on what they think will be helpful. So we'll role model that for you all. At the end, if you would like to see like what maybe a screen brief intervention refer to treatment would look like, I'm happy to do that. If you think that's just too much, then we won't do that. So what I'm hoping to kind of get across is that you can understand some of the prevalence of opioid use disorders for adolescents and young adults, appreciate some of the risk factors for opioid use disorders. And I do want to ask y'all later, so I want you to think about something for a moment. One of the risk factors identified is a family history of substance use disorders. And I'm kind of wondering, for those of you who work with peds or in other settings, if you're aware there's a substance use issue in the family and you're working with a family member who's being exposed to that, I'm wondering how you deal with that, if at all. And then lastly, recognize some prevention and treatment strategies for opioid use disorders in pediatric populations. Now, this is my favorite slide. I always like to kind of let you all know what's going on in terms of what pediatric populations are probably the music they're probably listening to right now. And by the way, that first song, in case you're curious, that was actually Lil Wayne performed at the national championship, Clemson versus Alabama, on national TV. So if you're wondering, well, that's more obscure kind of stuff. No, this exact song was performed on national TV with a lot of college age and younger people. So the name of the song is Uproar, and one of the lines is, if she sipped lean, and those of you who heard my presentation before, lean is slang for codeine-based cough medicine that many people drink. Double toast, y'all. So basically, they'll both drink it. Future has a song that's very popular where the chorus is Molly, and by the way, Molly is slang for ecstasy. Molly Percocet, I can barely move. Kodak Black, this is a very popular song right now. It's all over the radio. I'd be sipping on lean, trying to stay balanced. Again, referencing codeine-based cough medicine. And last, Post Malone, I'll spare you the F word. I'm sure you've heard it. I wake up, rinse my mouth with effing codeine. So if you're listening to top 40 music, which a lot of adolescents, young adults are, these are things they're hearing. They're seeing it very much glamorized and normalized and promoted. So prevalence and trends. So this is from U.S. Department of Health and Human Services. In 2016, 3.6% of adolescents aged 12 to 17 reported misusing opioids over the past year. 7.1% aged 18 to 25. And the vast majority are still reporting using prescription opioids rather than heroin. But again, I think there's been even more of a shift from 2016 to 2018 in terms of the accessibility of prescription opioids. So we're probably not quite tapping that yet. And by the way, just while we're on this note, I think I did this for a presentation before, which is why I didn't do it this time. There's the osamagram, which is specific to drug use patterns in Ohio by county. You just Google osamagram. It's super interesting research, and basically it kind of describes what are the accessibility, the prices of different substances in counties in Ohio. And last I looked at that, which I think was from June of 2017, the reports were that it was much harder to get prescription opioids, or what had been prescribed prescription opioids, and significantly easy to get heroin, fentanyl, and carfentanil a little bit less. Again, that's dropping, but fentanyl and heroin were easily accessible. And also this trend of finding more fentanyl in substances like cocaine and methamphetamine. So, well, I guess my take-home message here, and it was pretty much by county the same rates, is that adolescents probably have as easy access to fentanyl as they do most anything else. So the death rate due to drug overdose among adolescents aged 15 to 19 more than doubled from 1999 to 2007. Then it declined somewhat from 2007 to 2014, and then it's increased again somewhat. And that increase is somewhat thought to be related to that increase in fentanyl and carfentanil and those substances. One thing to think about, though, in terms of whenever you're looking at drug overdose prevalence data, it's incredibly challenging. For example, we know that some of those overdoses reported there were actually murders, where it was very young children who were exposed to opioids from their parents in an intentional way. We also know that suicide is oftentimes what actually the suicide completion was the rationale for the overdose. And it's very hard to know what's what, right? So you kind of want to look at any kind of overdose and not assume it's necessarily unintentional. 40% of the adolescents who died died of an overdose at home. So here's some more sort of prevalence. Again, this is more of your prescription opioid misuse appears to be decreasing. Past year misuse of Vicodin decreased from 10.5% to 2.0%. Jamie is messing around in front of me right now, and I'm easily distracted like a bird.
Sorry, I realized the mic was on the table, and I didn't realize I don't know how well people could be able to hear, and I'm hoping really well. But
so past year, obviously, cotton misuse decreased from a peak rate of 5.5% in 2005 to 2.7%. And in 2010, 54% of 12th graders believed that opioids were easily accessible compared to 35.8% in 2017. Clearly, 35% of the 12th grade population believing it's pretty easy to get opioids is still pretty scary. And again, I think that's not including access to heroin and fentanyl. Russell and colleagues, so these are risk factors. And I thought this was kind of an interesting study because there hadn't been many like this that I saw. They surveyed 31 adolescents enrolled in substance use recovery high schools about basically their patterns of substance use leading to opioid use disorder. And so the average age of substance use for these folks who eventually became dependent on opioids was 11.5 years. The most common drugs used at that point in time were alcohol, nicotine, and/or marijuana. Average age of opioid use onset was around 15. So there's this sort of gap from 11 to 15. So why did they use, right? 50% reported motivation for escalating to opioids was friends were doing it, which is why clearly what we know about adolescents, young adults, is that peers are incredibly influential, but so are families and adults. And I kind of asked you the family adults question because you're more likely to kind of know what's going on with them. Secondary motivations, or I think we're kind of like your sensation group, your sensation-seeking group of folks. Curious to find out what it felt like, and I like to experiment. So those are some of the secondary motivations for increasing from nicotine, alcohol, and marijuana to opioids. This is still that same study. Most of these folks were, or I guess 48% reported using at least 4 or other substances with opioids. Most of the sample were using at least one other substance along with opioids. 58% reported that their opioid use led to an opioid use disorder. So, you know, it wasn't really that easy to experiment, I guess you could say. Many caught a habit, as people would say. More than 90% had a family history of substance use disorder. So more than 90%, again, that's why I was kind of asking y'all's thoughts about that. And 42% had a family history of opioid use disorder specifically. So by the way, one of the things I do a lot with people who were raised in families where substance use disorders were present, and they experienced interaction with those folks, I oftentimes, in almost a knee-jerk way, bring up Al-Anon to them. It's just a really nice community for people to explore how substance use issues impacted their well-being. Like other 12-step meetings, not all jump on it, many don't, but it's an option I put out there for people. So where did they get their first opioids? 61% got their first opioid from friends, 7% from family, 3% for dealers. So it's not really these dealers behind a bush selling, right? That's a lower frequency event. 16% stole them, and 13% had their own prescriptions and began to abuse them. So here's another kind of interesting study that had to do with kind of trajectories of opioid use. So this was a 2016 study. It was took place in a federally qualified health center. The sample was comprised, the total sample of 1,076 folks. They were predominantly identified as African American or Black adolescents, 12 to 18. So what they found were sort of three trajectories. The first is, kind of like you'd expect, 90% of the sample was a completely non-using group throughout, did not use opioids. May have used other substances, but not opioids. This was specifically looking at opioid use. 5.9% of the sample decreased over that 12-month period. And then another proportion of that sample, 4.1%, were high sustained. So their trajectory, maintained that pattern of high use. And this is a little bit more on that study. So first of all, risk factors that they identified for any opioid use was any other substance use, delinquency, so kids who are already getting into some other criminal justice type issues, parental drug use, so again, that comes up, friends drug use, depressive symptoms, and suicidal ideation. So those were all risk factors identified in this study for any opioid use, either the escalating or the sustaining or the de-escalating. Now, this is kind of a weird finding. So they looked at what differentiated the group that decreased opioid use over time versus those that sustained opioid use. And they found that fringe drug use, that's not surprising. So the more they hung out with people who use drugs, they continued to use drugs. However, lower severity of depressive symptoms actually was associated with the group that was escalating or maintaining their opioid use. And they didn't really have a good theory as to why that was, and just to say that's not been found in other studies. So again, my take-home message is that human beings are very complex, and it's hard to know exactly what's happening with people. But certainly depressive symptoms in general are a risk factor for exposure to opioid use.
Was that a self-report study?
It was self-report, yeah. So this is kind of like one of these summary articles in the Lancet. The title was how the pediatric workforce can address the opioid crisis. And the American Academy of Pediatrics, many of you probably know this, has released a policy statement calling for expanded access to medication-assisted treatment, specifically buprenorphine and naloxone treatment for youth. Buprenorphine and naloxone combination, sometimes commonly known as Suboxone, is FDA approved for adolescents age 16 and older, and has demonstrated safety and efficacy for youth with opioid use disorders. As far as we know, I was asking some folks in here, there's research to suggest that naltrexone extended release can be helpful for adolescents to treat opioid use disorders as well as alcohol use disorders and even non-suicidal self-injurious behavior. But the position statements, to my knowledge, it's still not an FDA-approved use of naltrexone, and there's not any kind of bodies coming out and saying that naltrexone extended release should be used with this population, though I think it's probably upcoming. And some of you may have different information, so we're happy to entertain that. So these are a couple more of these recommendations from the Lancet. 9 out of 10 youth with addiction in the USA receive no treatment, and those receiving treatment rarely include medication. So you're really getting the picture of what could be helpful for this population is really being underutilized. Primary care-based MAT, and this is very much like what adults say about primary care MAT. It allows youth to receive family-centered care from trusted provider in a familiar setting. I always like research, there's not this with youth, but there is with adults, where, I always want to know, what do the people who are using heroin on the street think about what would get them into treatment? That's honestly what I'm most interested in. And there's a pretty good proportion of folks who say, if I could just go to my regular doctor and do this, I don't want to be going to a community mental health center or quote unquote a place where people think I've got this or that or the other. I want to go to my normal place and get my care there. So by extension, the argument is that this would probably be the same with youth, and it would be in a more kind of family-centered perspective, because that's what pediatric care is anyways. But, you know, part of the problem is only 1% of the U.S. Addiction Medicine Board diplomats are pediatricians. And they're arguing that all pediatric providers must learn to prevent and treat addiction, even if it's not through getting your DEA X waiver and prescribing buprenorphine, but nonetheless to have some sophistication with preventing and treating and certainly referring people to drug treatment. So this is another kind of one of these position papers in the Pediatrics 2016. And it reviewed a few randomized clinical trials that were related to buprenorphine treatment with younger folks, pediatric populations. And so this first study in JAMA, 15 to 21-year-olds randomly assigned to 8 weeks of buprenorphine before tapering, had lower rates of illicit opioid use while taking buprenorphine than the group assigned to 2 weeks of buprenorphine. And the differences disappeared quickly after tapering. So basically, there's always this push in the medication-assisted treatment world to taper people from their medications. And there's, first of all, there's no empirically supported method of doing that. So, you know, that's an issue, right? And secondly, it's a mindset thing that there's the belief that people need to be taken off this crutch. For some people, that might be what they want, and that might be part of a collaborative decision, and no harm, no foul there. But it shouldn't be the knee-jerk that you get somebody stable and then you taper them. And basically, they're arguing the same thing, that even with this population, they recommended not tapering if the patients are doing well and want to stay on. This General Archives of Psychiatry article, 13 to 18-year-olds who received 2 weeks of buprenorphine were more likely to engage in treatment than the group who received clonidine for the same time period. And they kind of argue in this that what we know about adolescents is they're even more skittish about engaging in treatment than are adults who are already skittish about engaging in treatment. So if buprenorphine, when used appropriately, can be a way to engage people in the treatment process, then that's probably a good thing. So this is a bit about screening. So maybe we're not ready to get into full-on buprenorphine prescribing, but some screening. And I didn't go into this in great detail because I did it in a previous echo, and also it gets a tiny bit out of the scope of the presentation. But certainly we can talk more about it. But fewer than 50% of pediatric providers report screening adolescent patient substance use. Of those, or only 16% use standardized instruments, and only 30% provide that brief kind of motivational interviewing type intervention. So this is seen as another area that the sort of pediatric workforce could maybe augment their approach, is to begin to engage in screening and some brief intervention and referral based on that with standardized instrument. So this kind of it wasn't an outcome study so much in terms of overall outcomes. It was really like an implementation study, and also to kind of see in this setting if SBIRT made sense. This was a 2018 article. I try and usually pull for more recent articles. They did an 18-month mixed method, so it was quantitative and qualitative. Examining the implementation of SBIRT, which is screen. So you're using some kind of standardized screening like the CRAFT, which we've gone over in another echo. The brief intervention, which is a motivational interviewing, a brief style of motivational interviewing, and then refer to treatment. So you try and get them somewhere. This was across 27 community mental health organizations serving about 2,800 adolescents. So first of all, they use the CRAFT or the UNCOPE, which are both validated adolescent drug screening instruments. And clearly that's what you're wanting to shoot for, is using a validated adolescent drug screening instrument. First of all, that's just the right way to do it. Use the right tool for the right person. But secondly, that allows you to bill because you've used now a psychometrically validated instrument for that population. So essentially, like in other SBIRT interventions, based on the screening, there was a negative, there's basically a negative outcome, low risk patients, positive reinforcement. Wow, that's awesome. You really take care of yourself. How you been able to do that? Right? Like you really kind of celebrate the fact that they scored low on these instruments. The moderate risk patients, and how you define that's based on the particular instrument. But you do the brief intervention, which is, again, a motivational interviewing based intervention. And then the high severe risk patients, you would refer to treatment, but though you'd also be doing a brief intervention, you wouldn't just say, here's your referral. But it'd be an attempt to really kind of more in the collaborative style say, I really believe you need to be referred to treatment, rather than kind of making it a little more open. So first of all, they found of these 2,800 adolescents, so all of them were screened. This was a bit surprising to them, though it did kind of map on to other data suggesting kind of the positive hits or whatever you'd say in screening wide swaths of adolescents. But about 53% received a positive drug and alcohol screen. Of that, 28% of the positive folks were referred to treatment. And 57% of those referred to treatment actually attended the appointment, which in the drug treatment world, that's pretty dang good. So there was, it was kind of perceived as, okay, this is a thing to continue to try to work on. Some of the barriers they found was folks were having a hard time identifying billing codes. Billing always comes up. So that led some people to be kind of stagnant for a minute. Securing behavioral health partners, that comes up everywhere. Like maybe they're there, but are they good? Will they communicate with me? Can they engage adolescents? So that's issues. Informing parents of results, that's something that comes up on here. People were really kind of tongue-tied in terms of how to elicit from the patient what's going on, while they're also minors and the need to report some things to parents. And then SBIRT, motivational interviewing and SBIRT are things that seem very easy. But the research in randomized clinical trials of how people learn these interventions suggests it takes quite a bit of time and practice and feedback. So it's harder than people think. So that was one of the other issues related to barriers, but the author concluded, authors, that it was a worthy endeavor to continue to try and implement across these settings and perhaps others.
I like the fact that a psychologist created id billing codes,
right?
Not the ego, superego.
Right, yeah, right. Yeah, that is true.
The groups, that's all.
That's true. It's all about me, all about what I need. I need stuff to buy. So this 2018 study described, this is kind of interesting. This described sort of a model in your typical pediatric primary care practice, though if you think typical involves having a social worker on board, but that's what they did. And you can see it was very brief. So it's from 3/2017 to July 2017. But basically they were doing screening patients with substance use disorder, either through the screening instruments like we mentioned, or just perhaps the patient reported it, just verbally, or perhaps the parents came in and said this is an issue, or the schools or whatever. So they took, all three of those kind of domains of information to identify substance use disorders. Then patients with substance use disorders who were identified were referred to this integrated clinical social worker who was right in the practice, right? So it's sort of like your best case scenario with that type of thing. And I know that's not possible for everybody, but maybe it's aspirational for some. So in those months, they also, by the way, the physicians got their X waiver and could prescribe buprenorphine, which was the really interesting kind of I guess, a way of augmenting the full array of services. So 683 patients aged 12-22 completed a health maintenance appointment. Of those, 20, so a smaller number than the previous study, were referred to substance use disorder treatment. 13 completed at least one substance use disorder treatment. The mean visits once people engaged were 5.3. And then 3 patients with opioid use disorder specifically were induced on buprenorphine. So pretty interesting, right? To me, that they had that sort of full suite of services for that population. And that the way I think about this a lot is that, yeah, that's 3 people over 4 months. What would have happened to those 3 adolescents over 4 months if they had not had that intervention at that time? Who knows? So that's my story, and I'm sticking to it.